Hello, it's an honor to be here today with you. I'm going to talk to you today about guideline implementation, moving evidence into clinical practice, and that's what I do. We're going to talk about methods that are utilized to create guidelines and describe ideas provided about guideline implementations. How are people moving this into practice? And we're also going to talk about how this has changed practice when clinical practice guidelines are written and established. So the largest group in the world that I'm aware of, at least, their entire goal in life is to push out guidelines and move things along, is the Guideline International Network. And their URL is here. They were established in 2002 with 111 organizational members, and they have 240 individual members from 61 countries. But their goal here is to improve healthcare via evidence and implementing evidence-based guidelines. Right? And they try to facilitate networking and collaboration, national and or international. They try and bring the best minds together to support continuous learning and improvement, and also reduce duplication of effort. So the idea of, do we need 15 different guidelines on knee pain? Probably not. We probably need one really good one that can be translated across countries and languages, and that's probably where the world is heading towards. In terms of guideline development, just to give you an idea of how this all works, you have to have a professional organization to sponsor the effort, and they can be anywhere from low to high cost. So they can be probably as low as maybe $10,000 to do, up to $250,000 to $500,000 is what some of these things actually cost, depending on how much data they have to read through and actually synthesize the data. You have to have enough data to write a helpful guideline. So you can't write a guideline if there's 3 papers that are out there that suggest that this might work with this particular PICO question. So you've got to have enough data. And the PICO question includes the patient population, the intervention, the comparison, and the outcome. So those are all critical elements in terms of writing a good PICO question to answer, and it has to be very specific and precise so that you can actually answer the question for the people who read the guideline. Now, in terms of how this all works too, you've got to recruit a multidisciplinary team to be authors. It always amazes me when I see 1 or 2 people's names on a clinical practice guideline, because you really are supposed to have a nice multidisciplinary team that gives you input into the guideline. And for the clinical practice guideline, recently we had a patient involved, or patient care group. You need different kinds of physicians. You need a physical therapist, an occupational therapist, for example. We had an audiologist involved. Sometimes people will use nurses. We had a chiropractor involved too. Because sometimes they will actually treat people with dizziness, et cetera. So that any member of the team that might be involved should actually participate as part of the guideline development team. You need librarians on board to help conduct the search and assist with the keywords. And from there, you need to review that search that they did and choose appropriate abstracts. And 2 people have to agree that the abstract should be included. Then you have to retrieve the papers that have been chosen, that you think that from the abstracts that have been reviewed, and review those manuscripts to see if they meet the criteria for review. So are they specific enough to what you want to know about? Very similar to what you do with a systematic review. And you extract the data from those papers with trained data extractors. And that's not easy either, because first off, you've got to get the people, and then you need to train them in some systematic way so that you can say that they can retrieve the data in a systematic way, right? So that they're reliable with their data extractions. Now, you've got to use a system, something like Covidence, to help you stay organized. Otherwise, it's a disaster. Then it's time to write based on the information that you've gotten from your data extraction process, but you need to usually go back and research and see if there's other things that might have come up over the last 6 months or years since you finished the first data search, library search. And then the CPG needs to be sent out once it's written. You think you're done, you have to send it out for review to other professional stakeholders for review and comment, so that it truly reflects not what you think or what the physical therapy profession thinks, but it's what the world that uses this CPG thinks too. The first one that I was involved with, the first CPG, was in 2008. It was a clinical practice guideline for benign paroxysmal positional vertigo. And I think we were the first team in the world in a CPG that actually said what not to do. So we said, don't give drugs and don't do MRIs or CT scans, et cetera. Don't scan these people because they have no value and it's additional healthcare costs. So we thought that was a bad idea. In terms of how often are these things cited, they're cited a lot. If you look at the first clinical practice guideline for benign paroxysmal positional vertigo, it was cited 125 times over a 9-year period. So 125 over a 9-year period. The second CPG that came out was cited 111 times over a 5-year period. So it's almost double in terms of the number of citations here in the new one. So people are using these things, they're reading them, even though they're outrageously long documents generally. So what we tried to do was we actually tried to figure out, Dr. Dunlap did this project at the University of Pittsburgh with Jenna Freeberger and Samanas, and what we did was we tried to figure out if physicians actually were adhering to the guideline. And we looked at the period, this was from the National Ambulatory Medical Care Survey, the ambulatory care clinics who had people who came in with BPPV, and they were all over the age of 18. And actually, persons with BPPV was 1.2% of the visits were actually coded for BPPV. So 1 out of 100 actually had it. My guess is it's probably more than that, but that's what was actually coded. And what you're looking at here on the x-axis is time, so these are years. And on the y-axis, you're seeing the percentage of visits, all right? And if you look here, this is these are adherent visits, all right? So these are people who did not order an MRI and who did not order medicine. And if you look at the primary care physicians, which is this black dot, these black dots at the bottom, they have significantly improved. Well, I shouldn't use the word significantly. They have definitely improved over time. So starting here at 42%, and as a group, they're probably close to 80 here on the upper right. So that's a marked improvement since the first CPG was published, because that came out in 2007, right about here, okay? Then if you look at the neurologists, they've actually gotten worse. So it's a smaller group, obviously. They went from 96% adherent down here to about 80. And then the otolaryngologists in yellow here are pretty stable, slightly worse too. But if you look at this overall, you can see that there's still room, there's 20% room for improvement here in all groups, because that's this, and especially the primary care physicians, that's the group that needs to be targeted, because they're the ones that see the most patients as compared to the otolaryngologists and the neurologists. So what we tried to show was guideline adherence here, and the issue here is that people are still getting medicine that they don't need, that makes them groggy, and sometimes increases their chance of falling if they're an older person. And most of these people who had BPPV were in their mid to late 60s. I think the mean was 67 years of age. Now, I was involved in another guideline, the Vestibular Rehab Practice Guideline for persons with peripheral vestibular hypofunction, not BPPV. And this came out in 2016, and there were 3 of us that were involved primarily. I mean, certainly there were a lot of people involved, but as the primary authors, the 3 of us put together a lot of the efforts here, and Courtney Hall led the team from Tennessee. And what people have done with knowledge translation is, once you write it, how do you get it out? And this is a CPG set into action, and I don't know whether you can see, but it's free. So what people are trying to do is open up some of these knowledge translation resources through the American Academy of Neurology to people, so that they can change their practice, whether or not they're a member of the group. I wanted to share with you too that you can see there's 3 new names here Anson, Carrender, and Hoppus. And the reason there's 3 new names here is because you need to think about succession planning. And whenever you start a guideline, you need to have a plan for who's going to write the next guideline. And so these 3 have definitely committed to being on the next guideline development team for vestibular hypofunction. And I put this in just to tell you that not all times are they totally up to date when you publish these guidelines, because it takes about 6 to 9 months at least to get them published. And they go through a review process before they even reach that. So this is a paper, for example, that I thought really should have been in the most recent guideline, but it missed the cut because you have to stop at some point and get ready, start getting ready for the next guideline. But what this guideline does, or what this paper does, is it very carefully outlines time. So they looked at persons with vestibular hypofunction before rehab and after rehab, and each of these boxes indicate either early rehab, this is the late rehab group, and this is the super late rehab group. So this is 0 to 2 weeks, this is 2 to 4 weeks, and this is past 4 weeks. And regardless of what treatment they were given, either protocol 1 or 2, what you can see is that the group over here and here, who were seen early in rehab, actually did much better. So there's always going to be something new to add. Just like with back pain, you see them early, they get better faster. Same thing with dizziness is what this seems to suggest. We also have looked at predictors of physical therapy referral among people with peripheral vestibular disorders. So who actually is getting referred from this large database, and looked at 5.5 million weighted visits of adults with BPPV and 6.6 million weighted visits for other peripheral vestibular disorders. And what we found was that the visits for BPPV increased in terms of being sent to physical therapy by 6.7%, but the visits decreased for other peripheral vestibular disorders. So BPV is going up, for other peripheral vestibular disorders are going down. And if they have private insurance or they saw a neurologist, they were more likely to be referred. So there's different patterns of referral that are occurring, and location makes a difference too, of where they're being seen across the United States. So people across the US are not getting standardized care and standardized referrals of care, and that needs to change, because it shouldn't matter where you live, whether you get the correct care here in the United States. What are people doing related to information sharing and knowledge translation? So there are some podcasts that are official and others that aren't. This is an unofficial podcast called OCS Field Guide about the meniscal lesion CPG. So people were talking about these things, trying to share them on social media. I wanted to also talk to you about how some of these things are being produced. So this was a paid gig or a paid job where the American Physical Therapy Association paid consultants from the American Academy of Orthopedic Surgeons to help fast track this guideline. So they did the search, they did the data extraction, and then the American Physical Therapy Association recruited some very fine authors to put this together to fast track this, because people, insurance companies were saying, we don't want to pay for physical therapy management of total knee arthroscopy. And we were saying this really helps. And without evidence, you can't say that. So they wanted a CPG. So the American Physical Therapy Association actually paid for a CPG to continue this care. And there are also, in terms of clinical practice guidelines, there are these things called knowledge translation task forces, where they provide new resources to people. So people are trying to push out clinical resources as fast and as quickly as they can as they're being published. And what they've actually started is doing some of this knowledge translation work before it's even published, so they can come out almost at the same time. There are other groups that are doing work that are not clinical practice guidelines, but are consensus-based documents. And I'm involved with the Baronese Society, which is an interdisciplinary group of people with an interest in people with balance and dizziness disorders across the world. And they've produced these consensus documents where you have to have at least representation of 3 to 4 different types of clinical practitioners and at least 4 parts of the globe represented when you write these things. And then they're published free in the Journal of Vestibular Research. And In addition to this, the group is also trying to standardize education. And if you get people educated and use guidelines to educate people, then they may actually do more compliant guideline practice when they're out there, and also when they're teaching others. So we're trying to get the teachers to teach other people to use the guidelines. And we actually produced a publication about what physical therapists and other health providers need to know to be competent and also to become an expert in terms of caring for persons with vestibular disorders. So there's neurologists, audiologists, physical therapists, otolaryngologists involved in this effort. And we came up with this paper that's in press called Curriculum for Vestibular Medicine, proposed by the Baronet Society. So we're trying to identify what are the key ingredients that you need to know to be an expert or a really good basic clinician. And part of that involves educating about CPGs. And just as an aside, there's a European partnership here, European Network for Vertigo and Balance Research, that's actually collecting data from across Europe to be able to get big data to be able to answer questions about people with dizziness. The World Health Organization is also developing guideline teams. This is what I'm aware of. It's probably much bigger than what I know of, but they're working to review diagnosis-specific guidelines from around the world to streamline and simplify information. They've recruited experts from multiple specialties to make these documents comprehensive for care, and they'll be translated into different languages. They plan to release the information within the next 6 to 12 months. And what I know of is a group related to head injury, stroke, Parkinson's disease, and wheelchair standardization. And the goal of the World Health Organization is also to enhance and improve care. This is an interesting paper where they took all the papers that talked about guideline adherence and did a systematic review. And what they found was that guideline adherent physical therapy management of persons with back pain is definitely cheaper. So you're going to see people starting to do what we did, was look at who's actually guideline adherent and how do we improve guideline adherence in groups. And this is just an aside, but patients actually read the guidelines too. So I had a patient recently who went to the hypofunction guideline that I helped write and said, why are you giving me this when it says I'm supposed to do it this many times and you gave me less? And I had to explain why I wasn't guideline adherent to the patient, because all of these things are free access. So patients are actually pulling these guidelines too. It's quite interesting. So how are people sharing these guidelines? The authors are sharing them, doing podcasts, obviously through publication. Non-authors are doing publications through the sponsored organization, and non-authors are interpreting these guidelines that are unofficial via social media, and then through the development of these knowledge translation tools and apps that professional organizations are developing. So our ultimate goal of clinical practice guidelines is to improve quality of care, decrease costs, decrease unwanted and unwarranted variations in care, and decrease burden to the patient, their time, their copays, their pain from additional testing. They're all unnecessary. So we need to figure out what they need to do and what they don't need to do in order to have the testing available that can best optimize their care. So the use of CPGs are improving care globally. People are working on translation of CPG documents to broaden the reach to non-English speaking, the non-English speaking world. CPGs are time consuming and require many people to assist in the data gathering, the synthesis and writing of the final document, and succession planning has to be started almost before the document and the team starts to write. Who's going to do it the next time? So working together as a team makes a difference and improves care. And I hope that this helped you a little bit better understand CPGs, and we'll take your questions later.